Dr.Apipop Kritsaneephaiboon. Dr. Apipop. Good morning, everyone. We talk about the pelvic fracture with shocks, how to save lives. So let's take a look with the case. This is major general military patients who got the Black Hawk helicopter crash, and the patient when the blood pressure is very drop on blood pressure and high power rate, and he got multiple injuries. He had a right pneumothorax that we inserted the chest tube. We have anterior compression fractures up lumbar level, and also he had unstable pelvic fracture that we initially applied with pelvic wider. So the first X-ray when he came to our hospital, and this is a binder that applied at the regional hospital. When you take a look in this pelvic fractures, it's very high unstable, and he is not in a good condition. So the question is, what is your emergency management or how to save his life? So in this talk, I'm going to overview and discuss about the initial management for the unstable pelvic fractures like pelvic binder, anti-external fixators, pelvic C-cams, and some reviews or comments about the resuscitative screws. So as you know that the initial management for the pelvic fracture, we have to start with the resuscitation of the patient, that we have to follow the ATLS protocol. And we have many things that can save life, like a pelvic binder, external fixator, pelvic C-cam, and also some without sections. All of these things you have to done before you proceed to the procedure that we call the ongoing breathing, and you have to do the pelvic packing, and also sometimes we have to consult the interventionist to do the angiography. So for the pelvic binders, you have to place it in the correct positions. At the trochanter level, because you have to leave the lower abdomen free in order to allow the general surgeon to assess the abdomen, and also sometimes you have to do the fast or laparotomy, and sometimes the patient had the bladder injury, so you have to consult urologist to do the suprapelvic catheters, and also sometimes you have to do pelvic packings. So always at the GT level. So after you apply it binder, if the patient had vertical shear fractures, what you have to do tractions. If the patient had open book fractures, you have to do internal rotation of the leg, and you have to apply the elastic bandage surrounding the ankle and the knee all the times, before or after you apply the pelvic binders. And this binder should be placed all the time until you replace with external fixators. And you have to be careful about some type of the pelvic fractures like LC injuries, that if you do overcompression, it can cause some injuries. And this is a picture that you have to apply pelvic binder all the time until you replace with external fixator. So now we proceed to anti-external fixators. All of you know that there are many advantages of the anti-external fixators. This is commonly available in every hospital. It's very easy to applications, and it's ideal for the APC2 injury, right? And some drawback from the anti-external fixators have some pin tract infections, and sometimes it's very difficult to control, especially when you do over reductions. And what do you think about this fix? It's a fancy, right? It's very strong construct, right? However, you have to think about your team. You have to think about your general surgeons. This external fixator on the left side is obstruct the lower abdomen, the whole abdomen, right? So you should leave the lower abdomen free in order to allow the general surgeon to do something with the if the patient has multiple comorbidity. Okay, so which one do you prefer between the X-fix and supra-external fixator X-fix? So all you know that the supra-external fixator have a much more stronger in terms of biomechanics, but you need the C-arm control, right? On the other hand, for the pin X-fix, it's very quick and easy to apply because you just palpate the bone and then drill and apply the shunt pin. However, because the pelvic bone is a very thin bone, so this pin X-fix, sometimes, or most of the time, this pin always go out of the bone. It's penetrated to the outer cortex of the pelvis. So for the pin X-fix, I have some point that some tip and trick that you need to be considered if you would like to apply this. So insertion point should be at the thickness of the part of the crest, right? Should be at the tubercle of the border. In the thin patient, you can palpate that position. And this should be direct to the point to the hip joint, but not go into the hip joint, because this is a thick part of the iliac wings. And also, you have to be careful about the very thin bone, especially the internal border of pelvic iliac wings. So when you take a look in the shape of the iliac wing, it's at a lateral overhanging, right? If you would like to do and insert the pin, should be keep your pin to a bit medial from the center, right? So your pin will go into to the bone, not penetrate to the outer cortex, right? So another thing is you have to be confirmed because the shape of the pelvic is like this, right? So the direction of your pin should be at the shape of the pelvic anatomy, right? When you take a look on the right side of the pin, from your overlook from the foot of the patient, you see that it's not into the right orientation, right? So this pin is not a good position. Always go out of the bone. So for the supraacetabular pinnings, you need C-arm, you need loosen tables, and if you listen to Ajahn Rahat lecture yesterday in real life surgery sections, all of you know about the landmark and also the position of this pin, right? So your orientation should be 10 to 20 degree craniously and 20 to 30 degree medially in order to the pelvic anatomy. So you start with the AP X-ray, and you need just drilling just very 1 or 1.5 centimeter, and then you have to insert the pin by your hand in order to feel the bone thickness, bony corridor, right? And then you can check with the iliac oblique view in order to check that your pin is above the gathered sciatic notch. And also, if you would like to check the corridor, you have to check with the obturator inlet view. And the teardrop view is just for the final checks, not just for the insertion point, because the teardrop view or obturator outlet view was always obstruct your surgical field. And the question is, in some situation, it is possible to do this supraexternal fixator without C-arm or very less C-arm. You can do it. You just make an incision as normal that we do when using the C-arm, but you need to make an incision more larger, like this, and then you can see the AIIS bone. And then after that, you just put your finger in the inner cortex of the pelvic ring, and then you can do it as when you do it with C-arm control, because your finger is your reference. This is the bony corridor reference that when you drill it, it follow your finger. That means your pin is in the bone. So if you are not sure, if you are just begin to start to do this, you can just do one shot of C-arm to check with the oblique view, and also you have some time, you can use the obturator inlet view to check the bony corridor. So do the same thing on the opposite side and apply the rod connections. So this is a case that I did it without C-arm because the patient got a multiple injury. He has a hypertension, and he has a pregnant 28 weeks. So at that time, we were not sure that her baby is still alive. So we don't want to take a risk. So we do it without C-arm. So we just do the technique that I show you. Just make a larger incision and put finger in and insert the pin both sides. And then this follow up with the CT post-op. And you can see both pin on both sides is in the bony corridor, no penetrations. What about C-cam? You can use this one as a, because this is a compressed directly to the posterior side of the pelvis. So this is good for the C-type fractures. However, it's a very technical demand and you use the C-arms. And the instrument is, I think it's difficult to apply. And you need technical demand to how to do it. What about this one? The anti-shock screws is a form of resuscitative screws. And this is acute stabilization at the SI joint or posterior stabilizations with the precunious screw fixation. And this is ideal for the dissection injury like SI joint widenings. However, this technique you need technical demanding and experienced team and also a lot of facility in your hospital. So another option, if you still have ongoing bleeding, you have to go for the pelvic packing and also angiographies. So in this unstable fractures pelvis, you need teamwork. So you have to build your algorithm and your treatment guideline in your hospital in order to save life and improve your outcome. So let's get back to the case that I started when I started the lectures. So this one, because these are very unstable fractures, we do the DCO. We brought the patient to hybrid OR at 6:30 in the evenings. We apply C-clamp. We do angiography, embolization intraoperatively. Because of we found from the CT scan that they have superior gluteal artery injuries. And after finish the operation, we brought the patient back to the ICU at 8 to 9 p.m. And still labile blood pressures. The patient needs 3 units of blood platelet cells and also FFP 1000 cc's. The hematocrit stopped from 38 to 32. And this is portable X-ray. But you take a look in this, it's like, oh no, right? Because the previous X-ray before applying the C-cam is much better than this one. So this is C-cam is not going to the SI joint. I mean the compressed SI joint, right? It's still unstable. So what do you think? So I think it's no need for the C-cam anymore, right? You have to take it out and do something else, right? So this patient, we brought back the patient to the OR, which is 10 o'clock in the night. And the blood pressure right now is still labile. So we decide to, because this is a dissection injury, widening of the SI joint on the right side. And this patient, he has sarcal dysmorphisms. So we do first juxtative screw percutaneously at the S2 screw. We compress the SI joint with one screw because there's no very small narrow corridor as S1. So we have to do with S2 screw. So this is a C-arm control. After we put this screw, the fractures can reduce nicely. And we apply the supinational excavator on the front. So we did it only half an hour and minimal blood loss. Even it's an imperfect reductions, but it's acceptable and it saves life. And the vital sign of the patient is to become stable again. So this one at day 5, stable condition. So we do we add S1 screw under the navigation system because it's are called bismuth, and then we apply the plate on the front. So for the summaries, I think the unstable fractures timing is very primary concern. So do whatever you want, do whatever you can do for the patients. The binder, ECFIC, and CCAM are very important for the acute management, and there's some alternative options like resuscitative screw with packings and embolization. And you have to follow your protocol in your hospital according to your resource and facility. Thank you for your attention.